Hmm. Looking at the counter, seeing the numbers go up. Okay, now somebody left already, so
So we should start.
we should probably start. So hi, welcome to our webinar organized and hosted by the ENS trauma section. And on behalf of all speakers, I'm very glad that you joined. We want to talk about cranioplasty, which is somehow en vogue because there has been another webinar touching this topic just recently from the ENS. But ours is a bit more, I would say, profound, and we want to talk about standards, current standards, but also trends. And we have four esteemed speakers, and I'll just introduce them one by one when they give their talks. Please post your questions in the chat if that's possible. We can collect some questions there. You can also wait for the general discussion. We want to do a group discussion at the end for the last, let's say, 30 minutes. If you have very urgent questions after each talk, just raise your hand, and then we can also do a brief intermediate discussion, depending a little bit on the time as well. So without further ado, I'd like to introduce our first speaker, Harry Mee, joining us from Cambridge. And Harry, you are from the Division of Rehabilitation Medicine and Neurosurgery, so a little different approach maybe. And you will be giving the first talk about consensus statements and prospective registries from to what is the evidence for cranioplasty.
That's great. Thank you very much. Just share my screen. Great. Can you see that okay? Is that coming through? Fantastic. Well, hello, everyone. Yes, thank you very much for the invitation to talk today, Alexandra, and thank you to EANS for hosting the webinar. So my name is Dr. Mee. Yes, I come at this from a slightly different perspective. I'm a rehabilitation medicine registrar. I work in the United Kingdom, and I have a particular interest with the Cambridge group looking at neurological the impact that cranioplasty has on neurological outcome following traumatic brain injury. And I'm going to talk really to set the scene today for 10 or 15 minutes, just talking around current evidence base for cranioplasty, looking at the evidence over the literature over the last sort of 5 or 10 years, and look to see where possible registries and work is taking us moving forward. So we all know that over the last 10 or 15 years, there have been a number of randomized trials looking at the role of decompressive craniectomy for traumatic brain injury, both as a primary and a secondary measure. And this has led to an increased number of decompressive craniectomies. If we look at hospital episode statistical data from the UK pre-pandemic, we can see that on average, there's been about a 15% increase in the number of decompressive craniectomies from 2014 to 2019. And this is very much led therefore onto an increase at the same number of increase in the numbers of cranioplasties. We do about 1,400 craniectomies a year, and that translates into about 500 to 600 cranioplasties a year on a national basis. But the cranioplasty is not a new entity. It's been around for many, many years. It was first formally described by a Flemish physician back in the early 16th century called Fallopius, where they described that a bone could be replaced if the dura was not compromised, but a gold plate considered if the dura was broken. And since then, there have been various neurosurgical developments around cranioplasty and to what is now a commonly practiced neurosurgical procedure throughout the world. Although as we know it as cranial reconstruction, it's not without its difficulties and complications, and it needs to be carefully planned as we will discuss over the following hour or so. We know that the cranioplasty is there to aid protection, to help with skull contouring, and can mitigate the effects of the sunken flap and treat formally the syndrome of Trephind if it is present. But also there's growing body of evidence suggesting of a impact on neurological outcome following cranioplasty. The International Classification of Functioning Disability of Health, as described on the right side of the screen, is a process and a way in which we can put together rehabilitation programs, and it's an important health aspect when we look at planning any health intervention, certainly from a rehabilitation perspective. And it's important to note that the cranioplasty, we should be viewing this within someone's rehabilitation program rather than just something that happens many months or many weeks after a particular brain injury. There are many clinical and research considerations around cranioplasty, and these have developed over many, many years. There was a consensus meeting on post-traumatic cranioplasty in 2018. I'm sure many of us are aware of the manuscript on the front here, but essentially it was separated down into 5 key areas of interest, both from a clinical and an academic perspective. So the first one was indications and technique, and I'll touch on that, but my neurosurgical colleagues, I'm sure, will describe that in more detail later in the webinar. The second is looking at materials, and then timing, hydrocephalus, and pediatrics. So I'll spend a couple of minutes just touching on each of these separately. So indications and techniques. The discussion focused on post-traumatic cranioplasty and covered both unilateral and bifrontal cranioplasties. I think the overall consensus was that there should be the cranioplasty, regardless of the timing of such, should be considered in as many patients as possible if it was plausible to do and it was appropriate to do. So this shouldn't be something that should just be decided and potentially done or not done. It's something that should definitely be considered in all patients if in the right clinical setting. Material-wise is a very interesting area. There are many different materials that can be used for cranioplasty, as we know. Globally, the most commonly used is the autologous bone, but that isn't without its difficulties, especially around rates of bone reabsorption. And certainly over the last 5 or 10 years, synthetic materials have certainly taken over. In the United Kingdom, titanium plate and titanium mesh are the 2 most commonly used material types. But there are many others. There's no single consensus as to which is the optimal material, and perhaps registries is one way that we would or should be moving towards to be able to get better longitudinal data to look at longer term outcomes of different material types. Hydrocephalus was the third key area that was discussed within the consensus meeting. I'm not going to read all of the 9 points here, but these were the results from the voting that was done within the conference. And I think the main area around this was there was agreement that there was a huge amount of uncertainty around the optimal way to manage patients with post-traumatic hydrocephalus related to the brain injury and also related to the cranioplasty. And further work and further research is needed to get definitive outcomes. From the pediatric perspective, really, they have looked at 3 main topics within the pediatric population. I'm only touching on this really today because there could, I wasn't part of the consensus meeting myself, but there really could have been a further consensus meeting purely on pediatric cranioplasty, but the materials, timing, and defining specific parameters around pediatric care is key in this context. And again, there was general agreement around these 3 areas. Timing is very interesting, and I know we've got a talk. One of the talks later on is looking specifically at timing, but just to do a few general points on it. I think there's continued debate around what is the optimal time to perform a cranioplasty, and we don't yet know that. Classically, the delineation of time has come at pre and post 12 weeks. That's within 3 months or greater than 3 months. But I think it's, as was discussed within the consensus meeting, this has to be based on a per patient perspective, and there has to be an optimal time for the individual patient to have the cranioplasty. And it felt that the delineation of time was perhaps slightly academic. Having said that, there were other time delineations that were agreed on, and that's looking at ultra early, so within 6 weeks, between 6 weeks and 6 weeks, between 6 weeks and 3 months, 3 months to 6 months, and then greater than 6 months. But I think the actual definitive time point around when is the optimal time to perform the cranioplasty is still not known. Why is that important? Well, traditionally, it was thought that your increased rate of complications occurred if you had an earlier cranioplasty, and therefore cranioplasties were often done 6 months, 9 months, or longer following the decompression, and that was really to try and reduce the risk of complications. The overall risk of complications, regardless of timing of cranioplasty, is around 20% in the literature. Now, that does vary hugely, and it depends on definitions around complication rate. So, for example, infections, in some places, it's the infection rates of 30 or 40% because superficial infections are included, skin infections, for example. In other places, it's much lower because an infection is only counted if a cranioplasty or brain, the plate actually has to be removed from a patient following an infection. Another one is hydrocephalus. So the rates of hydrocephalus vary hugely. This again is dependent on whether you include radiological enlargement of ventricles or the need for ventricular peritoneal shunting. So there are variations in complication rates, but if you looking at systematic reviews, and this is one of them here, the overall complication rate is about 20%. Interestingly, that was independent of timing of cranioplasty. So here they looked at those that happened within 3 and greater than 3 months, and there was no change in overall complication rates in the two groups. So since this has been looked at carefully in a number of other systematic reviews as well, the cause for a delayed cranioplasty due to increased risk of complications has actually been looked at formally now. There are other complications associated as well. The sunken flap syndrome or syndrome of Trephind is one of them, and this is one of the reasons for an expedited cranioplasty. And also other such reasons such as seizures, as I say, hydrocephalus infection are key areas to consider. But also from a timing perspective, there's this concept of neurological recovery. So what we mean by that is how someone has improved following their cranioplasty. The pathophysiological consequences of the cranioplasty is thought to be one of the key considerations about why some patients seem to improve more than others. Again, there's ongoing research in this area in many different countries, and we don't yet have the definitive answer, but it's thought to be due to changes in cerebral spinal CSF hydrodynamics, contralateral and ipsilateral improvement in cerebral blood flow as well, and cerebral oxygenation. But again, there's no definitive output here about why some people seem to improve and some people just don't improve at all, and I'm sure we can all think of cases where we see both of these. This is just some other examples of relatively recent papers and manuscripts looking at the association of earlier cranioplasty with neurological improvement. When we try and look at neurological outcome, we also be very clear about what we mean by that. And there's a huge variety in the way that neurological outcome is measured. That's not just associated with cranioplasty. That's in any neurological output, really. But obviously, here focusing on cranioplasty. There are many different ways of measuring neurological outcome, from a global functional outcome, and obviously the GOSC, the Glasgow Outcome Score Extended, is one that we commonly use within the TBI literature. But there's also functional independence, there's physiological outcomes, cognitive outcomes, and more basic parameters such as your Glasgow Coma Scale as well. And I think until we have a better way of standardizing what we need to measure, it's very difficult to look at those meta-analyses and compare studies. This was one study showing looking at changes in neurological state post cranioplasty, but the variation in the outcome measures made it very difficult to make comparisons. Having said that, on a very simple level, there was some evidence of both motor and cognitive improvements in the earlier group, or more motor and cognitive improvements in the earlier group compared to the later group. This was another systematic review by De Cola et al. Looking at neurological outcome again for cranioplasty. And in here, again, there were great variation in outcome measures used, but it did show that there was improved motor function, specifically if a cranioplasty was performed within 90 days, and not necessarily any cognitive or psychosocial improvement. So in what way can we take this forward to perhaps find better ways of collating information together in order to understand this and look at the literature more broadly? One of the ways we do this is looking at prospective registries. There are a number of cranioplasty registries across the European communities. The German Cranial Reconstruction Registry was launched back in 2013 at a similar time to the UK one. The German registry has closed formally now, but reported on such a few years ago, and I'll touch on that in a moment. Registries are there to be able to monitor basic demographic details. Hopefully it will enable practice pattern comparisons between different services within the registry itself, and looking at longer term impact of cranioplasty. Again, it can help with understanding neurological impact, functional outcome, quality of life, and complications by providing aggregate data over a number of different parameters. This is quite a complex slide, so I'm not going to spend too long on it, but it was really just comparing the four registry, or four of the prospective registries within Europe or the European Union. The registry within the UK, the Italian, the French, and the German registry. Some of these are actively collating data currently, others have finished collating, and others are in the process of starting. And it's just to demonstrate that although there are some differences within each registry, broadly speaking, we're looking at baseline basic craniectomy details, functional status, the procedure details themselves, the implant, and any removal or complications associated with that. The follow-up and long-term outcomes, which is really important from understanding material types and other issues, as we've discussed, can be very difficult. And there are many challenges around follow-up in any long-term study, and especially around long-term cranioplasty follow-up as well. And I know there have been challenges across the registries that are in place currently. Certainly within the UK, it's very difficult to get sustainable funding for long-term follow-up. That's something that we're trying to explore at the moment. But as I said, both the UK and the German registry have published data pre-pandemic, and both looked at a broad data set of what was of all cranioplasties within a set period of time. I won't go into the outcomes from those today. Just broadly, and I know I'm running over a little bit, but just to give a little bit of update about where we are with the UK CRR at the moment. So we've got nearly 850 entries now into the registry from just under 700 patients across 25 neurosurgical sites within the UK. About a two-thirds to one-third demographic split between males and females with an average age of 45. Out of those insertions, 80% of them are new insertions, and indication for craniectomy is as on the left there. We have about a 10%, 10 to 15% 10% removal rate, slightly higher complication rate within the first 30 days. And the majority or half of those reasons for removal are because of infection. As I said at the beginning, overwhelmingly so, we use synthetic materials now, and overwhelmingly so, the most common material we use is titanium in 80% of those cases, and we use just less than 10% or autologous bone, and actually it's probably less than that year on year now. But the cranioplasty, although the complications are a key consideration in the neurosurgical practice, as I'm sure we'll talk about in the webinar later on, we need to be better at looking at the longer term outcomes. The cosmetic effect, the psychological impact of cranioplasty is so important. The use of helmets, both pre-cranioplasty and the effect that they have on the psychological impact of rehabilitation programs are an area that is particular of interest of mine. Cranioplasty and the effect of return to driving on seizure rates, vocational rehabilitation, and the effect of flying, although seem relatively issues that might only come up a bit further down the line, where if someone is following their cranioplasty, is still really important considerations. And I'm sure we've all touched on all of these areas when we see patients in clinic following cranioplasty. So in conclusion, it's not a simple procedure. We need to make sure we have good multidisciplinary approach right from the offset, and really that starts from the point of the decompression. We need to plan ahead to make sure that the cranioplasty can fit into a rehabilitation program. We need to be aware of the rates of complications, but not necessarily mean that's a reason not to do the cranioplasty, and integrate it into the rehabilitation pathway where appropriate. And then we all need to look at improving our long-term surveillance of these plates. So I hope that's given a bit of an overview about cranioplasty, some of the current literature, and some of the work going forward. And I'll pass back to Alexander. Thank you very much.
Harry, thank you for giving this excellent introduction and also sharing a lot of your work and data, and congrats to all that you have been doing with the registry, especially on outcomes. I see that in the chat there's already some discussion, and there's also a question asked that needs to be answered. I'm just wondering whether or not we should go into the discussion now. I think if we do so, we just take too long. So I would propose that we continue, and then we can actually go through either the chat, or people can raise their hand again, and sure, we can answer those questions.
Okay.
All right. So,
yeah.
If that's okay, Harry, and the others as well.
Yes, of course. Yeah, absolutely.
Okay, great. So next talk will be a then more neurosurgical topic. Dirk Lindner from the University of Leipzig in Germany will give his presentation on actually doing a cranioplasty and especially handling complications. Thank you, Dirk, for joining us and for giving this talk.
Yeah, hello. I hope everybody can hear me. Okay. Good. I will start. I'm from Leipzig, in the eastern part of Germany, and we have a special interest and specification for cranioplasty and decompression, and that's why I'm also interested in this part. And as Harry has told us, there is a this is a simple surgical technique, and I have to talk about this some practical parts about the intraoperative situation and complication. And I mean, we have complication up to 50%, maybe 45%. It's so high, but it's a simple technique. There's a discrepancy between these both facts, and we have also a revision rate which is dramatic for the patient. From 5 to 30% with the loss of the cranioplasty at the end, maybe. So, and we have a problem. There is a low number, maybe on one hand, for really prospective or randomized data. It's really seldom. So, at the end, there's a big problem, but maybe it's not known, or it's not really the weight is not so high for this problem. So I focus mainly on these four literature or papers. Harry has talked mainly about that. My based lecture is on the multi-center study from Germany and also from the prospective registry of cranioplasty in United Kingdom and Ireland. And also I thought a little bit about this consensus statement in the NABL 2 years ago, which was very interesting because there are people from all over the world and they have totally different ideas about cranioplasty than we think in Europe is normal or unnormal and so on. So what are the main focus? If we look practical, before we start with the cranioplasty, we have to look to the risk factors of the patient. And the first risk is simply the number of operations were done before. And the operation number is a really important value. Also the patient age, it's clear if you compare patient with 20 years or 80 years, it's totally different. We will hear something about timing of shunt and cranioplasty. Is it different? Is it the same time? What is better, and so on? And we have also to think about the hypertension and other comorbidities like diabetes and so on. And this is very, very important. We have to look to the neurological and clinical status. This means maybe this is normal, but I think sometimes these patients came from the rehabilitation center, and then they are on the unit, and we have to make the cranioplasty operation. But if you see these patients in the daily routine, they often are without any movement of the legs. The MRS is maybe 5. So I think, from my personal point, that's patient with a dysplastic situation. We have to think about, is it really necessary to perform a cranioplasty, or is it maybe better to create a helmet and look for better rehabilitation and so on. This is a big fact in the daily routine. So again, for the young surgeon, it is necessary. You have to go to these people and you have to look to the head like this monkey with the other. What is the situation of the wound? Yeah. Is there a big scar? Is there a thin skin? What happened with the vascularization in this field? Some of these patients have local infection on the other part of the body. So you can really easily avoid some problems during and after the operation. And for me, it is really important that you also create, or you need a new CT scan before you operate. In Leipzig, we are focused on 14, maybe 21 days, so 2 or 3 weeks, not longer. Of course, this is the state of the art. This is the situation. You compare later after the operation. And again, we talk about an operation with a high number of complications. And I think, therefore, it is really important to start with an optimal situation. And it's also interesting to think a little bit more about the head shape. So I will present it. In our German study, register study, we presented some facts in 2018, and we measured also the number of intraoperative complication, and this was in comparison to the postoperative complication after 30 days past operation, only 2.4 to 2.7%, with no difference between autologous and computer-aided manufactured cranioplasty. Interestingly, the highest number was a problem with CSF leak, followed by hemorrhagic complication intraoperative and wound closure difficulties. Brain swelling and implant venting also happened, but in a really low number of patients. So if we look to the shape of the head, we have 3 different types, and this is really important. Type number 2 is the intermediate type. We know this is perfect for us for operation because the brain is in the same level as the surrounding bone, and this is easy to perform. But usually these patients are not so often. We see type number 1 with a big hole with a difference between the bone and the brain and the dura, and this type is much more difficult. And also type 3 with swelling and a level over the bone is often happen. This is type 1, a typical problem, an old man with a thin skin, and you can see it easily in this part. There's between the bone and the skin, there are only 1 or 2 millimeter. And this is a typical problem for later wound problem. And so you have to look to the head again, you have to go to the patient and you have to check how is the movement of the skin. Is it possible to move the skin from other areas to this area for a better wound closure? And this is really important. Other problem is you have to check the vascularization. Sometimes in Leipzig we use also indocyanine green to check is there a good vascularization or not. And sometimes we also use an expander for a better skin. This is relatively seldom, but I will show you some pictures. Also, it is interesting, in this type, we often find calcified dura, maybe also based on aseptic osteonecrosis. If you have a calcified dura and you have this people with the hole, again, you have to remove this calcification, because if you don't remove this calcification, then the dura is not movable, and you have a big room between the dura and the cranioplasty. And this is also often a reason for problems post-operative. Sometimes you have also to discuss what happened with the scar. In an optimal point from a neurosurgeon, it would be optimal to remove the scar, but then you haven't enough skin to closure the wound. So, and also in these people, it is very important to use the technique of tending sutures to make the dura movable to the cranioplasty. Another question is also the problem of drain, active drain, or antibiotics post-operative. Again, coming to our German registry, we had also measured the problem, or there are some with the tending sutures, and there was nearly 25% who never used this kind of tending sutures, and the other clinics used the tending sutures, and we could find the same number of complications. So at the end, there was a clear statistical point that the use of tending sutures is helpful in these cases. This is a typical intraoperative situation with a cranial mosaic, and so intraoperatively you have to look for the perfect border between the implant and the surrounding bone. Then the fitting is also optimal. The next problem is the tending suture. Again, there is no clear answer how many of these tending suture is needed. You have to check 2, 3, 4. Some people need more, but I think in this kind of type 1, again, head shape, it is really helpful. And again, it is helpful to look for the muscle reconstruction, the temporal muscle reconstruction, and also to use this periosteum together with the muscle to protect the room between the skin and the cranioplasty. This is also important for the vascularization in this area. So you have really look for optimal operation. This is an example for an expander. For this patient, he had 3 or 4 operations with a cranioplasty, and we had to remove because of wound closure problems. And at the end, we used an expander to create more skin for optimal closure. In another patient, we had this problem with an optimal closure of the wound in a white light, but with ECG, we could easily see there was avascular structure in the neighbor of the wound closure, and we could remove this part. And at the end, the patient had a perfect cosmetic result in this area. A second example is this old man. He had firstly a bone cranioplasty, but then the aseptic osteonecrosis happened, and he came in an urgent situation to us, and we created this nice titanium mesh to avoid a bigger problem. And at the end of the operation, we are totally satisfied with the shape and so on, and the CT scan was perfect. But 3 months later, the patient came to us, and you could see the pattern of the crab. So it was, we are not satisfied longer with the result, but the patient don't want any other operation. And at the end, he was satisfied, and that's okay. But again, if you have this thin skin, it is not optimal to use a crab or other cranioplasty with this problem. A third example is this young man with a car accident, and we had to remove the bone in different parts and also parts of the roof of the orbiter. And so the cosmetic result was terrible. And for this kind of protection and also for this 3D reconstruction, it is necessary to use a material which is optimal in 3D shaping, but also to that you can work with the material intraoperatively. We used a special plastic called PEG, not PEEK, PEG, because of the raw surface. And at the end, the cosmetic result was very good. But that's another point of this problem. So let's us come to the different types of head shape. The type 2, again, this is the intermediate, the best performer, and we should not have a big problem with this people. I think it's not really necessary to use tending suture, and for the drain sometimes you need it, but it's not absolutely needed. This third type, type 3, it's more problematic because he had the swelling, he had a different shape. It's thicker than the brain and the ventricular structure than the normal bone, and you must perform a ventricular punction or anything else to reduce this mass. So the question is, what is better, to drain the ventricle or to use a lumbar drain? And what happened with the temporal muscle? And should we what should we do with the excess of the skin? That's interesting questions. So there are only one publication from Heidelberg in 2018 about 14 people. So it's a low number of patients with the idea they tested the lumbar drain and they are really satisfied without complication in this patient. So maybe the lumbar drain is better than the ventricular punction. That's the question. if we ask in the German DGNC, the German Neurosurgery Society, 1/3 use the lumbar drain and 2/3 the ventricular punction. So it's nearly this. It's not usual, or it's not so often that the lumbar drain is used. So what is optimal? In our study, it was a little bit different. In a quarter of the patient, the ventricular punction or the CSF reduction was necessary, and in this remaining 85 patient, we had the same complication rate with ventricular punction in comparison to lumbar drain. So, but the number of lumbar drain was lower at the end. It is an advantage in this registration for ventricular puncture. So at the end, I can't say this is better than this. So it isn't easy, and it depends on the patient. Also, the question was discussed what happened with the drain, with the wound drain, and we had the same complication rate in patient with and without drain. So what are the red flags at the end for this, for the intraoperative work? I think you should look for optimal position of the head intraoperatively. You have to look for a ventricular puncture or lumbar drain for the type 3 with the mass excess. And for patient with the skin problem, you have to look for the vascularization. During the operation, it is clear we have the perioperative antibiotics, and you have to look for a clear border between dura and bone in the whole area for a perfect fitting material. You have to avoid the dura opening, and the periosteum fixation is also very important. And the drain, I think, should be active. CT scan after the operation is also good within 24 hours. Thank you for your interest, and that's a picture of the traffic from the day from Leipzig.
Dirk, yeah, snowy times right now. Thank you very much for your excellent presentation as well, and for highlighting and sharing complications and images. It's always really perfect.
Thank you.
Is previously, I think, decided, the discussion is really active there in the webinar chat. And us, the panel, basically, we can also just chat and talk to people during the talks, which I think is fine. But for the sake of time, we just continue with the next talk. So the third talk for today, and now it's all about timing. And Rick Rieberg from Leiden University Medical Center will give his presentation on ultra early too late, or too late cranioplasty.
Thank you, Alexander. Trying to share my screen, and I'm able to, because I think Derek is still sharing.
Yeah, true. I think if you can, perfect.
Yeah, that's the one. Yeah. So, all right. Well, again, thank you, Alexander, for the introduction and the kind words. And thank you for ENS for hosting this webinar. I'm Rick Vreeburg from Leiden University, and I'm going to talk a bit about the timing of cranioplasty. So Harry already touched a bit on the timing of cranioplasty. So I'm trying to add some relevant details and touch on the recent center TBI study we performed with an international group of authors, including Harry and Alexander. So I think the background is a little bit unnecessary, perhaps, with all these neurosurgical experts. So the most important part is that regarding timing, there's still a lot of clinical equipoise on whether it should be performed early or late, or in recent surgeries, even ultra early, within 6 weeks. And I'm going to give a short overview of the, oh, it's not correctly sharing it. Yeah. So I'm going to give a quick overview of the current evidence, and then touch on the center TBI study we did. So as you can see here, there was a recent review performed by Dr. Colias and Dr. Iacorino from Italy and Cambridge. And they gave a nice overview of the high variance in definition of what is considered an early cranioplasty or a late cranioplasty. As you can see on the far side of the right here, that there's it varies between 3 months or 1 month or 10 weeks or even 16 weeks. But the most used cutoff for early cranioplasty is 90 days. And as Harry briefly explained this, that was also voted on in the recent consensus meeting, that 3 days is 3 months is the cutoff for the early cranioplasty. As well as the ultra early cranioplasty, you can see in the medical literature that that's around 30 to 42 days as a cutoff. So if a cranioplasty was performed within 6 weeks, 42 days, then it's considered ultra early. Yeah, so as mentioned before, the evidence is very limited. There's a high variability in outcome measures, definitions for complications, for example. So I've tried to narrow it down and provide 2 most pragmatic main outcomes, which are the general and most frequent complication rates after cranioplasty and the functional or neurological outcome in these severe TBI patients. And based on the conclusions, they are also very variable, with certain complications being highly associated with early cranioplasty, or even not even or inversely associated with early cranioplasty and other research. And there were 2 main large systematic reviews and meta-analysis from DeCola et al. And Malcolm et al. From 2016 to 2018. And I found a couple of the large retrospective studies, which I've added as additional evidence. So we'll start with the complications as surgical site infections. Malcolm et al. From the systematic review included a total of over 2,000 patients from 18 different studies. And as can be seen in the top right, they found no pooled association between surgical site infections or bone flap infections or even fever after a cranioplasty, favoring either early or late. And that same no association can be found in a recent study by Eans et al. In a single center retrospective analysis of 435 patients. They also found no association between infection rate and cranioplasty timing. And a larger single center retrospective analysis by Morton et al. From 2017, they analyzed 754 patients. You can see the complication rate graph there in the right bottom of the screen. And they found an overall around 6 to 7% infection rate. And made the most of the infections were from the patients which were operated ultra early, or even you could say extremely early, within 14 days after decompressive craniectomy. Even a 30% infection rate within these patients. And the infection rate dropped after around 42 days. So bone resorption, also an important outcome of or complication of cranioplasty. Looking at the same systematic review, Malcolm et al. Also found no pooled association or between early cranioplasty or late cranioplasty and the bone resorption rate. So, it must be noted that they define bone resorption either clinically or radiologically. A large retrospective analysis by Rashidi et al., more recent, of 303 patients. They found around 10 patients with bone resorption, which was based on the clinical findings. And they also found no clear association. And again, the study by Morton et al., they found they did not provide any odds ratios or hazard ratios. But out of the 500 total autologous cranioplasty procedures, there was around a 6% bone resorption rate. And it showed a higher frequency in the cranioplasties performed after 90 days, around 3 versus 10%. Looking at hydrocephalus, there's another trend can be seen. So in the same systematic review by Malcolm et al., they found a positive pooled association with early cranioplasty and a hydrocephalus, so around an odds ratio of 2.4. But these findings were mainly based on a general pooled association. So there were no clear individual studies covering a grand association, a positive association. It was based on the pooled analysis. And Morton et al. From 2017 defined hydrocephalus as an hydrocephalus which required shunting. And they found an around 9% hydrocephalus rate, which was correlated with time to cranioplasty from decompressive craniectomy. So an odds ratio of 0.9 per 10-day increase, which means that the more time elapses between decompressive craniectomy and cranioplasty, the lower the odds of contracting an hydrocephalus were. And the same study, as mentioned earlier by Eans et al., found around a 3% occurrence rate prevalence, and they found no association between hydrocephalus and cranioplasty timing. So next are the seizures. Malcolm et al. Found no pooled association, but can be seen again in the table to the right, or the figure to the right. And again, Morton also did not find any significant difference in seizure rates, although the few seizures that occurred were all in the late cranioplasty group, so all cranioplasty performed after 90 days. And Eans et al. Again, they had around a 5% seizure rate, which matches that of Morton, and they found no clear association as well. And looking at perhaps a more important measure, which was functional or neurological outcome. And I'd like to begin by looking at these two systematic reviews and meta-analysis by Malcolm et al. And DeCola et al. And as can be seen on the first graph from Malcolm et al., there was a high variety in neurological outcome measures. For example, the Bartle index or the Konofsky score, or the regular, can I say, the Glasgow Coma scale. And based on these findings, they concluded that early cranioplasty is associated with greater neurological improvement. But as you take a closer look, it's mostly based on a study by Bender et al. From 2013 and a study by Kong et al. From 2014, which were single center studies and with relatively small sample sizes. For example, the Kong et al. Study had 55 patients with a very high odds ratio of functional outcome and early cranioplasty. And looking at the next one from DeCola et al. From 2018 as well, again, we can see a high variety of this was neurocognitive outcomes. With, for example, the MMSE being used, and a very limited number of patients which were included for the analysis. And there was no clear association found between any of the studies included, favoring either early or late cranioplasty, except for the possible improvement of motor scores when cranioplasty was performed within 90 days. So they included three studies, and they found a pooled positive association of early cranioplasty and improved motor outcomes. And adding on to that, for the early cranioplasty, because there has been a recent search in literature, but also in questions about if cranioplasty performed ultra early or within 15 to 30 days, that it might limit the risk of hydrocephalus or even infection rates. So Eans et al. Looked at this and they found no clear association as well. And a more recent review from Setti et al., another single center retrospective analysis of 77 patients, considered ultra early within 30 days, and they found a possible positive association of both cranioplasty hydrocephalus and ultra early cranioplasty compared to cranioplasty performed after that, which you can see here to the right in the red bottom. And again, Morton et al., as discussed earlier, they found an evident increase in infection and hydrocephalus occurrence when cranioplasty was performed within 42 days, which can be seen in the graph which we showed earlier. So in conclusions, there are large disparities in timing definitions, what is early, what is late, in complication rates, but also in complication definitions, so what is considered a bone resorption, what is considered infection. Some studies included by Malcolm et al. Even included infection rates as defined them as having a fever or antibiotic use. And there's a high variety in outcome measures for functional and neurological outcome. And most evidence or most conclusions drawn are based on rather low quality evidence from small sample size, single center retrospective studies, which was one of the reasons why the recent consensus meeting, as mentioned by Harry before, called for data from large multi-center prospective cohort studies, such as Center TBI, and providing bespoke recommendations for these patients. So that is one of the reasons why we performed, together with an international group of authors, we performed a prospective multi-center observation study within Center TBI and the NetCure database. Looking at the early versus delayed cranioplasty after decompressive craniectomy and traumatic brain injury. And we analyzed data from a little over 5,000 unique patients from Center TBI and NetCure. And we based the early versus delayed cutoff again on the available literature and the recent consensus meeting. And out of those little over 5,000 unique patients, 227 received cranioplasty, of which we included 173 patients. And we examined mainly as primary outcome the GO scores at 12 months, but also the quality of life as expressed using colibri or complications. And to provide more bespoke recommendations, we employed additional subgroup analysis, and to strengthen the primary outcome analysis, we conducted similar sensitivity analysis using propensity score matching. Unfortunately, we were not able to look at the autologous or versus synthetic data, since that was not collected in the either Center TBI or NetCure databases, unfortunately. So looking at the two groups we included, 73 patients were included in the early group and 100 patients were in the delayed group. And they were similar in important baseline characteristics such as age or baseline GCS scores. If they have underwent a major extracranial intervention or CT imaging, and possibly more importantly, the impact probability for unfavorable outcome or mortality. Notably are the differences in hospital length of stay, because the median score in days was higher in the early cranioplasty group. Why that was, we'll get to that later. You can see to the right the distribution of the cranioplasty timing, with a median timing of 101 days after decompressive craniectomy. Looking at the primary outcome, the GO score at 12 months, we can see the distribution here. And we can see that it doesn't show a clear, consistent shift preferring either early or late cranioplasty, which was confirmed by the ordinal logistic regression model we performed, showing no significant odds ratio, as well as for seizures and colibri scores. We did find a notable difference in hydrocephalus occurrence, 12% in the early cranioplasty group and 4% in the delayed group, which yielded an odds ratio of 4, which indicated that there was an odds ratio of hydrocephalus occurring in early cranioplasty of 4. And as well, if we're looking at timing as a continuous matter, rather than using the arbitrarily chosen cutoffs, recently we found similar differences, no significant difference in GOS or seizure occurrence. But we did find a difference in the same hydrocephalus association. It's a bit harder to understand, but we can see that as was done with the study by Morton et al., that the odds ratio is lower. So the odds of hydrocephalus decreases when more time elapses between decompressive craniectomy and cranioplasty. Looking at the subgroup analysis, we can see in this forest plot we looked at age or TBI severity, DC location, by frontal and hemicraniectomy, or if decompressive craniectomy was primary or secondary. We found no positive associations between early or delayed cranioplasty and GOS. We did find a notable difference in if a major extracranial intervention was performed at baseline, so during initial admission. And we found that if a major extracranial intervention was performed, that the early cranioplasty patients had a higher odds of GO and higher GOS, so higher functional outcome. And as a supplementary analysis, we looked at the ultra early cranioplasty within 6 weeks, but we did not find any association between GOS and ultra early cranioplasty. We did find very high inter-center and inter-country variability across Europe. There were over 65 centers participating in center TBI and NetCure. And we did see a median odds ratio of 2.3 for the center, between the centers, and in the countries of 2.1, which indicate a very high difference in likelihood of undergoing early cranioplasty, which also may indicate a possible difference in treatment preferences around Europe. So in discussion, we found similar functional outcomes, quality of life, and seizure occurrence between early or delayed cranioplasty. We did find a positive association between early cranioplasty and hydrocephalus. And we did find in our subgroup analysis a positive association between early cranioplasty in polytrauma patients. So what are the plus points of our study? So it was prospective. It was based on prospective data. It's a multi-center study. It's the largest population till at this point, due to the multivariate adjustment in our logistic regression model and the additional sensitivity analysis and the similar baseline characteristic between the early and the late groups. And we minimized the chance of residual confounding. And it was the first study to analyze quality of life in regards to cranioplasty timing. So one of the limitations is that with these heterogeneous study populations and in these highly confounding subjects, the residual confounding may still persist, especially confounding by indication. Unfortunately, we were not able to analyze data on infection rates or bone resorption, which, as mentioned earlier, are a rather important complication after cranioplasty. Another limitation is that the exact date or the precise date of hydrocephalus and seizures diagnosis are missing. So they were noted on the 3 months follow-up form or the 6 months or the 12 months, but the exact date was missing. So either when a cranioplasty was performed at 30 days, for example, the hydrocephalus may be diagnosed before those 30 days or after those 30 days, which was unfortunate. And GOES remains a rather crude outcome measure for measuring neurocognitive status. As mentioned before, there are high variability in outcome measure. We try to, as a pragmatic approach, we use the GOES for determining functional outcome, but it's not an accurate tool to determine neurocognitive status. So in conclusion, the study suggests that there's comparable functional and outcome and quality of life between early and the late cranioplasty patients. And therefore, there may be no reason for neurosurgeons to delay cranioplasty after the first admission, but they should remain vigilant on the increased possibility of hydrocephalus. And that was it. So I'd like to give the word back to Alexander.
Thank you, Rick, also for sharing your data and giving these hints towards time point and maybe earlier time points. Now we have touched this very important topic, timing, and the last topic will be very similarly important materials. And Johannes from Salzburg will talk about general alloplastic implant designs, materials, but also his own experience with 3D printing. And I'm looking very much forward to actually seeing and hearing what you guys have been cooking in Salzburg.
Thank you, Alex, for the invitation. I'm happy to speak about our concepts with 3D printing for cranioplasty. So I think my talk is the trends part of this lecture, and I will start in the past. No, I cannot. Okay, no disclosures, which is kind of important because I will talk about industrial stuff. When I came to Salzburg in 2018, we used a concept that was probably developed in the 50s. And when you got to the OR to do a cranioplastic surgery, you would get this tray of lead plates and a small hammer and scissors, and then you could cut the lead plate into shape, fill some PMMA inside, and adapted to the shape of the prepared head. And after heating started, you would redraw the whole thing, take out the implant, cut the edges, and then insert the implant. And this works astonishingly fairly well, but sometimes I've brought an example here. It looks like this. These are a pre-craniectomy, post-craniectomy, and post-cranioplasty CT scans. And this was, of course, not very good for us, not good for the patient. And we were lucky to have a very innovative department of oral and maxillofacial surgery right next door. So together with them, we developed a concept that we called springform technique. Some of you might know this kind of springform, and it's quite similar to what we did. This is a cranioplastic springform, and I will give you an insight into this concept. So to start with the design process, we did a segmentation at that time with BrainLab software, merging the pre and post craniectomy CT scans and taking a three-dimensional STL file into a planning program, a design program. We used Materialise Mimics Imprint at first, and then you have those two models, and you put a hollow around the pre-craniectomy CT model to take the shape of the head before the craniectomy was performed, and then you would cut around the craniectomy defect digitally, and then you would get two templates, hollow for the mold, and a ring for the craniectomy defect. Those are then printed on a desktop 3D printer with sterilizable epoxy resins, which looks like this. This is a laser STL printer, and after that a sterilization and hardening of the implant is performed. And then I brought to you this video to show how the intraoperative fabrication of the implant works. So we did this usually when the patient was still being intubated and brought into the RR. And as you might know, if you're into cake baking, you need to add some oil or butter. We use neutral oil in this case, and then you can nicely mold in the PMMA dough, and you can adapt the amount of PMMA to the shape you want to achieve. So if there's a lot of swelling, you would not take too much PMMA, and if there's a sunken flap, then you might take a little bit more to reduce the space inside the implant. So when the heating starts, you can take away the ring, and after that remove the plate quite easily if there's enough oil, and then the implant is ready for insertion right before actually the surgery starts. And this is what it looks like. We usually put in small holes and for the tenting sutures. And so intraoperative pictures of this look like this. This is a patient with a bilateral craniectomy defect. This is an intraoperative picture of a cranioplastic implant we did with this springform technique, and this is postoperative skull shape. And these are CT segmentations of postoperative scans of the same patient. And on the bottom, you can see the pre-craniectomy, post-craniectomy, and post-cranioplasty CTs, which show, in my opinion, a very nice reconstruction of the pre-craniectomy skull shape. So this is a concept not in detail, but in general that has been used worldwide actually in the last year. So it's quite common. I found literature from Brazil, from Mexico, Taiwan, Korea, Lebanon, Switzerland also, and of course the Netherlands. And we have used it for about 3 years now in Salzburg, and have had more than 50 springform implants. The outcome is usually really appealing. So patients were throughout the whole time very satisfied. Interesting is that even though this is a technically quite complex thing to do the whole 3D printing and design part, the total costs are striking compared to CAD/CAM implants, with about 300 euros, and all the buying the printer and stuff like this is included in this calculation. And the complication rates are comparable to other alloplastic materials. And what's really nice is that the planning and printing goes fairly fast. So if we decided to do a cranioplastic surgery, now we could do it like 3 days later without having an implant at the time of decision. And we also use it for some one-stage craniotomy, cranioplastic surgeries, like in the picture on the right bottom, where we removed a large skull meningioma and did the cranioplasty right away with the springform technique. So why didn't we stay with this? I don't know. I was asked so many times, why don't you just print the implant? And I would always say, I'm not sure if it's possible, and if it's possible, it's probably too complicated to do it in a legal way. And then again, the guys from oral and maxillofacial surgery came up with the idea of buying a printer that can print a PEEK and a fused filament fabrication technique. And apparently there was a printer at that time from Kumovis, now 3D Systems, that can print under clean room conditions and is designed to print medical implants. There's a printing material from Evonik Industries, also designed for printing human implants. And this is what the whole process looks like. And so we started a thorough process to develop this kind of workflow at our institution. And the easy part is actually to design the implant. We do it usually right now this way. We merge the pre and post operative or pre-post craniectomy CT scans via BrainLab Element software. Then we have a model from the pre and post craniectomy skull, and after that we send it to the Department of Medical Engineering in our hospital, and they will design with geometric freeform software an implant which looks like this, resembling the pre-craniectomy skull shape, and this is the implant, and support structures are added just for printing. Okay, so this is the easy part. The hard part comes here. It's called the EU Medical Device Regulation, and usually it's really difficult and costly to get an implant onto the market within the EU. Even in the if you do this as a company. But there is a magic article. It's called Article 5.5, and it's also called the Health Institution Exemption. And I have copied this part from the regulation, and it says that if you stay to the general safety and performance requirements, then the usual requirements of the regulation shall not apply to devices that are manufactured and used only within health institutions established in the union. So this basically means if you have a concept to design and manufacture a patient-specific implant that you give to a patient within your institution, then different rules apply. And those rules are laid out in this guidance article that I have put down. And it's all about validating a process of production. And that's actually what we did. And because we could not do this on our own, we got a lot of help, as I show you here, from the 3D Systems Kumovis company, so from the printing a company, especially on technical aspects. We had an external service provider called POCAP from Switzerland, who helped us to set up the production process, the whole quality management system, monitoring, and accordance to the EU regulation. And we had a lot of help, especially in the technical part from our Department of Medical Engineering. So in the process that I will show you right now, we define three main acting characters, so to say. That is the treating neurosurgeon. That is one second. That is a 3D printing expert from the Department of Medical Engineering, and the case manager. And so the whole process works like this. We do the data acquisition and segmentation. Then we send it to the implant designer, so to the 3D printing expert. They design the implant, and then they print template of the implant and the skull at the time post craniectomy. And then the implant shape and size and everything has to be cleared by the surgeon and the case manager. And then the implant is printed, which looks like this. The peak filament is melted under very high temperatures with this printing head, and then put layer by layer onto this plate. And the whole process is done under clean room conditions. So safety is ensured by the printing process. After the printing, the implant looks like this. Then support structures have to be removed, and holes are added in our process, and then the implant can be sterilized with steam autoclave sterilization. This is what it looks like intraoperatively. We also added the plates for fixation already. And before that, the implant has to be cleared again by the surgeon and by the case manager. So this is what it works like. And we did the first implantation of a 3D printed implant this September. The patient was 63 years of age, had a traumatic brain injury with right-sided subdural hematoma. She received initial decompressive craniectomy and had a very good clinical recovery. And this was the implant which fitted really well into the defect, was fixed with 4 4-hole titanium plates. And this is the post-operative, directly post-operative image. So we also use a drain. And this is segmentation of post-operative CT scan, and this is the outcome about 3 weeks post cranioplasty. This is a CT scan of the head. As you can see, we chose to standardize the thickness of the implant to 4 millimeters, which eases mechanical testing of the implants in advance. We could have also chosen a thicker or thinner variant, but this is very stable. So right now we have implemented this process as a standard of care in our institution. We did now 11 patients, actually 12, because today we did another one, with a total of 13 implants. So 2 bilateral cranioplastic surgeries were performed, and indications were mainly traumatic brain injury, 2 patients with malignant MCA strokes, and 1 intracerebral hemorrhage. So in conclusion, I would say 3D printing aided molding of cranioplastic PMMA is very feasible, cost effective, and quite easy to implement. At the same time, you could also choose to establish a workflow to 3D print cranioplastic PEEK implants. At least in the EU, it can be performed at the point of care in accordance with the EU MDR. And my personal outlook is that through this close interaction between the medical and the technical personnel about 3D printing implants, this can be used to drive more innovation in medical 3D printing of patient-specific implants, like also spinal implants or more complex implants. That's what we are aiming to 3D print also implants for example, for orbital reconstruction and stuff like this. So I want to end here and want to give very special thanks to the guys from our medical engineering department, from the Department of Oral and Maxillofacial Surgery, and of course to our industrial partners. So thank you for your attention, and I'm happy to answer any questions.
Thank you, Johannes. Actually very cool to see this, and impressive that you managed to start this. I'm not aware of any other center that is doing the same already. So now we have completed our 4 talks, and we still have time. So I think officially 6 minutes, but I hope we can take a bit of time to answer some questions. Some of you have already commented on open questions in the F&A section. So one option would be for me to go through the questions just briefly, and then we can discuss those together at the start. So first question from Peter Werdemann is about closing the skin. It's an interesting question. What would you guys advise, staples or sutures? And he also says that he has published a series. Okay, any comments? We suture. But
maybe I can give a comment. I'm not sure if it makes a difference. I rely a lot on the quality of the skin, so to say. So if there's an easy skin closure, I usually use staples. But if there's the skin is very bad and has bad edges, then I try to use sutures to get a better adaptation of the skin.
I'm not aware of any data on this, so this series that has been published by Peter Wellman might be interesting. Okay, next question. What's the PEEK implant cost? I think that basically has been answered by you, Johannes, in the talk, I guess.
Well, we don't really have data what the PEEK implantation will cost in a real life scenario, because now we have implemented it for the first time. So I cannot really tell. It's probably about half of the costs of an CAD/CAM implant, but we will have to wait for the real world data, because right now we just started with the project and got some reductions and stuff like that. Yes.
But yeah, but I think that this can be then also streamlined and costs can be reduced later on, and it's really hard to imagine how actually 3D printing or whatever PEEK implant costs. I mean, in Germany sometimes 6,000 euros. So I would hope that those costs would go down when you do this yourself.
We will be way below this price, but it also depends on how much you use the printer. So as I said, this 3D printing at the point of care can only happen for patients who are treated in your institution. So You can use it for craniomaxillofacial surgery. You can use it for orthopedic surgery, but it has to be all in one hospital for one printer.
Harry, can I ask you, do you know the costs of a PEEK implant in the UK? Because it would be interesting, because we are all from either Austria, Germany, or okay, Rick, you can also maybe comment. But so Germany would be around 6,000 euros for a larger defect. My experience.
Yeah, I don't know for a PEEK implant how much it would be. A titanium implant. So we have a service where we design them within our institute, but it was just too expensive, and the regulations were too difficult to get 3D printing on site. So we outsource the printing of the file once we design it, and that process is probably a couple of €1,000 for a titanium implant in total. But I don't know about the PEEK implant. No.
Rick, do you have any knowledge on this?
No, sorry.
Okay.
Not sure.
What are you using?
We're currently mostly using autologous bone. So the PEEK is up and coming, but it's still mostly autologous.
Right. Okay, then another comment here on acrylic cranial implants, also 3D printed, very interesting. And then is there consensus on why holes are post-drilled into the 3D printed implants and then the number size of the holes? I think, okay, Rick, Johannes, I mean, it's a question to you, but you drill those, otherwise you get companies drill those for you if you order an allogenic. I mean, there's no consensus to my knowledge on the number of holes, etc.
Actually, we chose to use a standardized way of putting holes, because this was the standard of care before, also for autologous implants and also for the PMMA implants we did before. Then we did it by hand intraoperatively. Now we do it in the lab when the implant is printed. So I don't know if there's any evidence if there should be holes or not. I think if you do not put holes, a drainage does not make much sense, because then you cannot drain the blood that can be under the implant. So I think the holes are mainly for drainage, maybe also for integration into the scar tissue.
Okay, so we had that discussion on this on a meeting just recently, and it's really interesting that depending on the department and surgeon, people don't actually do those sutures, for example, those holes for sutures as well. So so there's obviously a huge variability and probably no consensus. We do the holes for a lot of sutures, and also to drain, we also put drains. So that's non-evidence based, but so that's our procedure. Any other comments from you guys on holes in generally in the bone or in the implants? Okay. Adil, yeah.
I have a question to Johannes. Do you have shrinking problems with the thermal process in the 3D printing? So for me, it's interesting with PEEK. I know sometimes there's a problem of the accuracy, or it doesn't happen.
It would happen, but I did not show this. There's a step included in the design process. So the implant is designed, and then there's an automatic mechanism that adds. It's actually a learning algorithm that adds some size to the implant before printing to make it fit after printing, because there is shrinking of PEEK after printing. Yes. So you have to adapt for it, and right now we do it together with the printer company, and there's a solution, and right now we have excellent fits of the implant, so it's working well, but otherwise they would be a little bit too small, right?
And this algorithm was developed mathematically based on KI or anything or experience or
I think I'm not sure because I have not been into this, but as far as I know, it's a KI AI development. So the software is learning from the with every implant we make.
All right. Another question here. What is your protocol to preserve autologous bone flap? So maybe I can ask the panel in general. So Rick, you're still mainly using autologous bone. Johannes, so you not so much, obviously. Dirk and Harry.
also first the autologous bone.
All right. So it's still a standard. Okay.
Yep.
And Harry, for you as well, right? In the UK.
We don't use it very much at all anymore.
Ah,
No.
true. Yeah, remember now. Yeah, you have these legal reasons, right? Biobank. Oh, true. Okay.
Yes. Yeah. So I mean, it does still occasionally happen, but almost it's by far and away we synthetic materials has taken over. Yeah.
So we now do the same. We just recently we had a lawyers coming to hospital, being at a department and giving us advice and some regulatory people. And it turns out that, I mean, at least in Germany, there are certain risks attached to biobanking those bones, and we now also completely discarded the whole biobank and actually I sent letters out to all the patients that they can now come and pick up their bones, and we switched to synthetic materials for mostly legal reasons, but also for, I mean, growing evidence maybe that there might be some benefits. Plus, we did an analysis and we saw that we don't even implant less than a third of the bones that we take out, because so many of those older patients just die or have a bad outcome. And so we really biobank and we throw away, but it's a little inefficient. So if before we preserved in a -80-degree freezer, was our standard. Normally this has to be controlled, monitored, etc., which is difficult because you otherwise have liability if you cannot prove that you had biobanking conditions for this. Access has to be restricted and stuff like that. But that's still, I think, in Germany the standard of preserving those bones. Do you have any other techniques or?
So we have completely abandoned it for 3 years now. Also due to a new regulation which forces us in Austria to take swabs directly after explantation of the bone.
Already? Okay.
Material swabs, and it turns out that about 50% of them are positive with skin bacteria, so with Staph epidermidis or Cutibacterium acnes, and these have to be thrown away. So then you have only 50% left over, and usually only implant about 50% of the explanted. So in the end, you have the whole biobank for about only 30% of used implants and the long range complications. So we abandoned it.
Another question here about how to fix the bone. So in our case, we use microplates. I think it depends on institutional practices in general. Also, it's a cost question probably. I'm not aware that there's any differences. Pediatric is obviously different, but. And then there's an interesting comment: a 3D reconstructed patient-specific cranial implant for Mohammed Jihansip costs $150. So there's large differences to the prices we just discussed. Okay, any cutoff age for pediatrics to put in the bone? So that's basically that's the topic where there's more evidence, obviously. A cutoff. Do you guys work with cutoffs for kids? Or do you use age cutoffs? Now we are switched away completely, but for all pediatric and even young adults, even before that, we also did not reimplant the autologous bone. So without a fixed cutoff, but those numbers are quite. This is rare, so the numbers are quite small in our center, but this definitely even below 30 of age. There was this discussion a lot of times. Okay, another comment here. Yeah, obviously saving the bone flap in the abdomen is also a strategy, but I'm aware of evidence that points to increased rates of bone resorption for this method. So I think it has been discarded at least in a lot of centers in Germany for quite some time. Okay. And we have a lot of other questions in the chat, a lot of positive comments as well. We'll skip those. Optimal timing, I think we talked about this. There's even something I want to, maybe put to discussion. So yeah, individualize, yes. And then if you have those patient-specific implants, you sometimes have very, if you 3D print it, you have no delivery time basically, but even with some companies, you have very short delivery times, and you have implants that you can actually design so that they maybe can encompass a more swollen brain as well. So there is this tendency to, try to maybe in some individual cases put the implant back in during the ICU stay at the end of it, and then discharge the patient to the rehab. So Rick, that's a little bit also I think what you pointed out. This is a direction that things go.
Yeah. So what we found was that mostly patients were waiting on implants, especially on synthetic grafts. They were waiting on it, so they would be able to get discharged to a rehabilitation home, for example, but they still were waiting on their implant. And certain rehabilitation physicians were sometimes hesitant to start intensive rehabilitation without with a still evident cranial defect. So with our more recent experience, we've looked into re-emplacing the skull during the initial admission, or so that we were also considering that it might be more cost efficient to re-emplace the skull during the initial admission. So it would prevent a secondary admission and perhaps a longer length of stay.
Yeah. Okay, then a comment on lethal complication, ICH, large ICH after cranioplasty. So ICH is quite uncommon in our experience. Epidural, more likely. But this was it was discussed by the person who asked the question whether or not this is related to the drain, subgaleal drain. So I think if the dura is closed and you have the drain, I don't see necessarily where there is, an effect on the ICP, a strong effect. So I think it's a little bit debatable, but so we still use drains, and I've seen a lot of patients. The drains do not necessarily prevent epidural hematoma, but I've seen a lot of patients having very swollen defects, skin and muscle, and I think the drains still, there's no evidence, right? But still the drains, actually two mostly in our case, still prevent this. Also, the wound healing is improved, etc. But what is your experience? I think we talked about drains before, but just briefly, did you have this kind of complication where you have an ICH after cranioplasty?
With the drain, as I talked, it is important to use the active drain if you drain, I think, but there are different techniques, and I know there are some drains with a fixed pressure, so you can only open or close, and this is maybe more problematic than the types with different steps or levels of pressure, because the highest pressure is really strong, and so there is a mechanism in different patients that the dura changed or moved out, and so you can have this ICP changes. That's not. I have never seen it in more than one or to a patient, but there's a problem. So I would the solution is active drain, but with different level, with the percent. So not to use the drains with only pressure or no pressure. So this is maybe a solution for this problem. I think it's important to avoid hematoma epidural or subgaleal with this technique. Yeah.
Thank you. Okay, then some good points. What's the difference in outcome complications depending on what kind of dural replacement was used in the first surgery? So I think we all agree that doing cranioplasty is, I mean, you guys have pointed this out, it's not that easy as a procedure. It can be difficult sometimes, and also depends on the previous surgery, definitely. Those registries, maybe, I don't know if you looked at this in detail, what the previous dural reconstruction was. Are you aware of any real evidence that certain material or certain technique might be beneficial or might be, I mean, we all know that there are cases where the surgery is more complicated, and there's cases where it's very clean, the intersection plane. So do you have any suggestions for this?
So we haven't looked directly at outcomes relating to specifics around the dura, certainly, but we are increasingly aware that the impact that the craniectomy has on cranioplasty outcomes. And so we're trying to increase our data collection around the craniectomy procedure rather than just the very basic information around around craniectomy. So I think that's an area where we're expanding the registry. But it's, yeah, it would be interesting to look at dura and outcomes. We haven't done that specifically from our side.
Thank you.
So from my point of view, we are about, together with another hospital in Austria, to collect data on this topic, because they do it different from our standard of care. I believe that if you do a late cranioplasty, it does not matter that much, because then you have a stable dural scar. But if you do it really early, then just putting something underneath the dural opening and leave it there without suturing a dural plastic inside makes a lot of work doing cranioplasty, at least to close the dura again. So I think the time of cranioplasty matters on the effect of dural closure in the craniectomy.
Yeah, I would agree. Okay, the last questions here. Is there a recommendation, titanium versus acrylic materials? I'm aware of one actually prospective, I think, I don't know how it was controlled and randomized, but there is a titanium study out there published some time ago where titanium was compared to autologous bone and not to acrylic materials, unfortunately, but this is one of the only, I think, basically RCTs. And they just showed that while it's expensive, there's no bone disruption, which makes sense. But I'm not aware of any direct comparison, but this is obviously a topic where a lot of research is now going into, and people try to start those prospective trials comparing materials. Do you have any recommendation, Harry?
Not specific recommendation. It's very institute dependent and neurosurgeon dependent. We're heavily biased in our UK data on titanium, but that's because that's what's gained traction and is used commonly. I think it's a really good opportunity to try and develop maybe a European-wide registry. We are looking at that and trying to answer some of certainly the material question. We need to link up data from different centres and look at long-term longitudinal data around this. So no, I don't have any specific recommendations on one or the other. But it's needed, as you've alluded to.
I have no experience with titanium, to be honest, so no recommendation then. Okay, and one comment, very interesting. In the Punjab Institute of Neuroscience in Pakistan, patients get 3D reconstructed acrylic cranial implants for free. So that's obviously very impressive. Congratulations. What is your post-operative antibiotic protocol with the synthetic versus autologous bone? We have no antibiotic. We do no antibiotics after those cranioplasty procedures as a standard, at least. What about you?
I think there's no evidence that prophylactic antibiotic therapy is indicated in any surgical intervention, only if it's septic. So no, we just do intraoperative single shot. That's cefoxiam.
Yeah, we do the same. So perioperative and then no further antibiotic regimen. Okay, so we have completed all the questions. If there's no more, and the people have already quit, but thank you, the 74 people still in the Zoom, for staying, and thank you to the panel, each of you guys, for doing this and giving those talks. Thank you very much. It was really excellent, and thank you everybody for participating and discussing. Looking forward to seeing and meeting you all next time. One last thing, we from the ENS, there will be a survey on cranioplasty. It's going to be sent out soon, so very small one, 3 to 5 minutes, and I think you can even get an authorship if you participate. So feel free to maybe answer those questions. It's on mostly materials. Yeah. Okay, thank you. Bye-bye. Have a nice evening.
Bye.
Bye.
Thank you very much, Alex. Bye-bye.
Thank
Bye,
you,
guys.
Alex. Bye. Bye.
Thank you, Alex.